Thank you so very much. I am very honored to have this opportunity to do this talk. And I want to say good morning to all our teachers and colleagues here. Please, can I have my slides? Okay, so I think this is a grounding talk. There's been a lot of excitement. I feel excited about all the talk about laser. And I think another talk about laser is coming right after this talk. But so this talk is for you if you don't have access to a laser or that kind of thing. So what I'm basically doing is doing this talk on medication being the first line of treatment. And our learning objectives for this talk are basically to just do a very brief background overview about the concept of target pressure, the mechanisms of action of the drug classes, how much IOP lowering we get out of them, and which classes of patients should have medications as first line, and generally like that. So a lot of things in the background have already been said. There are many risk factors for glaucoma. The only one we can control, that we can measure, is intraocular pressure, and all of the stuff about the pathways. Now, we know that reduction in intraocular pressure is the goal of management of glaucoma, but how much reduction should we be aiming for? That then brings in the concept of target pressure. Now, with target pressure, there are so many considerations in deciding what your target pressure is, whether the person is expected to have a fast rate of progression or actually has a demonstrated fast rate of progression, whether the glaucoma is advanced at the initial stages, and that then goes into whether you are thinking of having a low or a high target pressure, feeding all of those considerations into setting what the target pressure is. And therefore, the target pressure is set for each eye of every individual patient. It's not something like a formula like that. Now, medications lower IOP by different mechanisms of action. And I'm just going to quickly scroll through classes of medications. I have some tables on them. Okay, so this is not working anymore. Right. So the prostaglandin analogs can lower intraocular pressure by up to 35%. And then the non-selective beta blockers can go up to 25%. And not like that, with systemic carbonic anhydrase inhibitors doing between 30 to 40%, and the alpha-2 selective agonists, and all of the medications like that, with all their how much IOP reduction they actually give. Vis-a-vis this discussion about our hitting target pressure with medication. So which patients should we be treating, and which kind of patients should medications be first line, especially if you do not have access to laser or the wonderful technologies that are exciting and stimulating about laser. So we're all familiar with this who to treat graph that relates, again, about how aggressively you need to be treating patients, about the onset of their glaucoma, and about the rate of their progression. I'm not going to do a lot about this, but I'm just going to go through. So a lot of these charts are from Nigerian glaucoma guidelines that state exactly what you should do with the different categories of glaucoma. So this is for the ocular hypertension patients. And for the Nigerian guideline, if somebody has a pressure of 26 millimeters of mercury and above, you should treat them. And what should you treat them with? If you have a laser, it's great. But if you don't have a laser in the room, can I see your hand? Okay. So it appears that everybody has a laser, but you should treat it. Oh, I saw only 2 hands. I asked if you do not have a laser, and I saw only 2 hands. So that's great. So in ocular hypertension, yes, you should make medications your first line if you do not have access to a laser. Now, for the early and moderate open angle glaucomas, your first line of treatment in the absence of SLT should be medications. And the medications may vary with the etiology, like you want to give pilocarpine to patients that have, prostaglandin analogs in pigmentary glaucoma and things like that. For normal tension glaucoma, you really would want to make prostaglandin analogs your first line of medication because they have good 24-hour control of intraocular pressure. And in acute angle closure glaucoma, even though medications are not definitive, they are definitely first line, because what you want to do is to bring down the intraocular pressure as much as possible, as fast as you can, to break the acute angle closure attack. So systemic carbonic anhydrase inhibitors to get as much IOP lowering as you can, as fast as you can. Now, the things about general principles in what exactly you choose in terms of patient preferences, efficacy of the medication, target IOP, adherence. Generally, all of these things play into prostaglandin analogs being the first choice medical treatment for most people. And then if the patient does not tolerate that first choice, then you switch the monotherapy. But if the patient has some IOP lowering, but it's not enough, then you can add a second medication for topical therapy. So this is the second to the last slide I have. And these are situations where medications really should not be your first line. Now, it's not really as if you cannot use medications in these situations, but they're not definitive as treatment strategies for any of these things. So in conclusion, the first line of treatment in many types of glaucoma is still medical therapy. And our aim in using these medications should be to use the least amount of medication that will give the patient the required therapeutic response. That is exposing them to minimal side effects, minimal preservatives and things like that. Thank you for your attention.